off point I am with the whole RSI and totally forgot about that. Okay, so pulmonology, quick little review. So what is this here, this location? Why is that important to us?
You don't want
to pass it?
Down the right.
So I thought about you guys this weekend, just so you guys know.
Oh.
Yeah, there's a little place in my heart. I gave my probationer a scenario. Okay, gave him a medical RSI. It was a COPDer that turned into an empty order RSI, right? Had lung sounds, but they were diminished throughout. He intubates and loses lung sounds on the left.
CD?
Dun dun dun.
On the left.
No.
So what happened? So what's the problem?
Down the right. Always get on the right page.
What's the right grade set? But what did this probate get hooked up on?
Go to the left.
He had no lung sounds on the left.
So he kept pushing?
So he doesn't, it doesn't even dawn on him that he had lung sounds before, but now he doesn't, right? So he's stuck with, he hears the term, I have no lung sounds on the left. But what does all new paramedics want to do when they have no lung sounds?
Needle.
They want to try and needle somebody, right?
Doesn't.
So,
You gotta-
can you blame the guy who's excited, nervous because I'm yelling at him the whole time, and I've been doing it all day long because it was EMS day for him. But at the end of the day, he walked into the office. He's like, "Hey, Captain, I just want to say I really appreciate you." And I was like, "Why? Is that because you've had a bad day?" He's like, "It just made me realize that I'm not quite where I need to be for my test in 2 weeks." I'm like, "Yeah, we got some work to do, right?" I was like, "So, you guys." He did not go through Lane, right? So most Lane students that go through Lane, like I can run that scenario through them. They're like, "Oh, I'm just gonna pull back real quick," because we've ingrained the fact of you do your checks, right? You're thinking, you're like, "Oh, well, that's weird. I had lung sounds to start off with, but now I don't." Lung sounds like that don't just. What happened between here and there? Well, I put an ET tube in. Oh, what's the most common thing that happens? Oh, go right main sound, right? So that's the kind of thinking that you guys are going to be able to go out there when you guys start your internship and stuff. You're going to run the scenario. And they're like, yeah, I'm just going to pull back. Pull back the first time. Yeah, no change. All right, pull back the second time. No change. Okay, now I can think about something with this lung, right? So you guys troubleshot and you guys work through. All right. So I was thinking about you guys. I was just like, oh man, if only you'd gone to school with these guys, you'd be dialed. All right. So as we work down, we got your bronchus, your secondary bronchus, all the way down to your bronchioles, down to your alveolar sacs, right? So when we're talking about respiratory emergencies, where do a lot of the emergencies occur that we can fix? Up here, right?
Yeah.
So a lot of the stuff is up here, right? Time to get up. So a lot of the stuff we can fix is up in the bronchus and in the bronchioles. What are the conditions down in the alveoli that we can fix?
CHF stuff. You can't, are you talking about fixing it?
You don't fix it, but you can.
Temporary help.
Okay.
We can't fix it. We can't fix a lot down there.
You can dilate
We could CTAP the water.
Go ahead. You can ratchet it up there. Almost there. Almost.
Lock the shoulders. Lock the shoulders.
Okay, so you get your gas exchange issues down here. So you're going to end up with issues related to COPD, right? Which is going to cause issues with your gas exchange down there. What kind of emergencies happen up in the bronchus?
Constriction, fluid.
Right? Constriction and fluid, right? Those are kind of the two big ones that we look at. What is this kind of made up of? What's
Cartilage.
Yeah, so you can have, so is it cartilage? Does cartilage change shape?
No.
No, it's pretty fixed, right? So it's everything that's on the inside that causes issues with us, right? So you got your smooth muscle, so you have your contractions there, you have fluid build up along your bronchus, right? Can we deal with both of those?
Yes.
Yeah. So a lot of the stuff that happens up here, we can fix. How about if you have a giant marble stuck in there?
No one's gonna give us
Not-
So
not
can you push the obstruction down further with your ET tube?
You can. So what's another way you can push stuff down further?
blow, like,
CPAP?
Pressure, right? So you can bag stuff farther down in there, right? But if you have something stuck at the cranium, you have no idea where it's stuck though. We're just gonna think theoretically. So say you got some sort of chunk of meat or something that's stuck suck down here. You've tried your what techniques beforehand? Before that.
Heimlich or
Heimlich.
back?
All your
back.
BLS stuff. As much as you guys are awesome paramedics, don't forget about the simple BLS stuff beforehand, right? So you tried all your BLS techniques, nothing worked, right? First foul, unconscious, unresponsive is turning into a code, you're almost there. So you try your forceps, you try your laryngoscope, you try looking, you try seeing, still nothing. It's down below the cords, right? So if it's down below the cords, down past where you do what? What's not gonna do you any good?
Right.
Right. So it's down past the cords, crack's not gonna help you. So you're basically, you're screwed, right? Not a whole lot we can do. Can we fix it? Not really. So
Could you push
we
it?
can only attempt to try and help slightly. We're not gonna get it out, okay? So what you can do is you can bag the stuff, you can bag it down and hope that it goes right main stem, because that's where everything wants to go, right? You hope it goes right main stem, because what's that give you? Gives you left lung exchange, right? So it gives you some possibility of gas exchange versus zero possibility.
So if you're saying you're going to bag this patient, are you saying that you're going to just positive pressure ventilation through a BVM with no airway?
No, because you're gonna pass,
Okay.
you're gonna pass your airway because you have to create
All
a
right,
tight
so you're going
seal.
to pass your airway and then bag them.
Correct, because
Good.
what's gonna happen if you have a total obstruction and you put your ET tube on there and you squeeze your bag, what's gonna happen?
Yeah.
Right? It's good, it's not gonna, because your ET tube's down there, right?
Yeah.
So you're gonna squeeze your bag and nothing's gonna happen, right? You're gonna activate your pop-off valve on your BPM, right? So what you need to do is you need to plug your BPM pop-off valve and then just squeeze and then increase your pressure in an attempt to try and pass that down to get some sort of gas exchange. Because as soon as you clear that carina to the right main stem, what's gonna happen?
Left
You're gonna-
lung's gonna go like,
All of a sudden you're gonna get, and be like, oh, okay. So you went from zero air going in to some air going in now. Better than you were? Ideal? Not really, but you're better than you were, right? Make sense?
have you ever like done that? Like how often is that like a thing that works versus like a theoretical?
I've done it one time,
Okay,
successful,
okay.
because we were out of everything, because they were like, the crew was like, hey, we're gonna crank this person. I'm like, thinking medic, hey, it's not gonna do us any good, because it was stuff that had gotten down past. Have you guys seen, what are those peppermint candies at Christmas time,
Candy cane?
yes, but the round ones, right? So, it was a, person that had swallowed 2 of those. One went down the esophagus and one went the wrong way, right? So it got down there. So we had the thought, I was just like, hey, why don't we just wait for it to like dissolve,
That's
right?
like
It was like,
pump water.
right, and then we're like, well, so like you start running through these stupid, not something that you want to say out loud, right? Because Martin could be like, really? Like, what? You know?
The other person's like, well, maybe we should try this.
Yeah, right? And then, but like, think about it, like how much oxygen deprivation you're going to have over that amount of time, right? So brain damage, it's gonna take more than 4 minutes for that potentially to dissolve. So, yeah.
Were they
so,
breathing before you got there?
They were unresponsive by the time we got there. But they had said it was like a late 40s female that had done it. But they said, hey, yep, she was eating this is what happened, she had 2 of them. And then, at first we thought it was some sort of allergic reaction initially. And then we figured out later based on inability to bag whatsoever with no lung sounds.
Oh, you guys thought it was allergic reaction.
Yeah, we thought she was having some sort of allergic reaction kind of thing, because they were like, yeah, she was complaining at first of having a hard time breathing, and then she did a little bit of the cough thing, but then they were like, yeah, you know, she's got all these allergies. They gave us this list of like 100 different allergies that she had, and we're like, so what does that automatically do? When you get a list of stuff, and somebody tells you, hey, I think this is the problem, what do you
You're like,
usually
oh yeah,
do?
let's go down that rabbit hole.
Yeah, it lets you steer you down the rabbit hole, right? So, it took a little while, I don't know, when I say a little while, a minute or so to kind of reason through everything and figure out before we finally figured out kind of what had happened.
So did you do epi at all? Did you try the?
No, because all that stuff kind of takes a little bit, and we're like, that's not making sense. Like, we're like, we don't have wheezing, we don't have hives, we don't have edema, swelling, we're not hypotensive. Like, nothing was making sense, and so that's where it's like, it takes you that extra minute to be like, okay, yeah. No, none of that's making sense, so we're not gonna continue that path, right? So that's where you start to back up, and then you're like, and then she stopped breathing, so now you're like, okay, I'm getting no compliance whatsoever here. Why?
Did you already intubate her?
No, we were still in the BLS.
Okay, so you're just trying to bag.
Yeah.
And are you noticing gastric distension or just resistance?
So it was just resistance. So we had resistance, but we were getting some movement. So we're like, all right, let's hold self maneuver in an attempt to, because that's kind of our steps. It's like we start bagging, we immediately grab self maneuver, start to kind of bag. Okay, yep, no. As soon as you start grabbing self maneuver, resistance increasing. You're like, yeah, I'm really having a hard time. Okay, well, let's go in with the laryngoscope and the Miguels and see maybe if there's something down there. Go down there, can't see anything.
What are the Miguels?
The
forceps.
upside down scissors that
Yeah.
you can go in and grab.
Did she live?
Oh, we'll pull those out later.
So she did not survive. We ended up in a full code shortly thereafter, and then they ended up finding on the chest X-ray. By the time the chest X-ray was done, it was like basically minute to nothing that was still there, and then they went back and tracked down some of the family events and history and stuff, and found out that that's what it was that she choked on. But what we did do is we finally intubated, and there's still resistance. So as soon as we felt that there was still resistance, we're like, well, if she's choking on something, let's just bag it down, right? Because we'd already checked, we'd already looked. So we start bagging, nothing, pop-off valve happens. We close the pop-off valve, squeeze, nothing. And then my partner was just like, squeezed really hard, and it's like, all of a sudden it was just like instantaneous, just like, okay, I got some compliance now. So now we're like, okay, did we blow out the side of the trachea or something? Like, what did we just do?
It went somewhere.
Right, it went somewhere. The air's going somewhere. And so we made the comment. We're like, well, let's watch for subQ emphysema now. Like, so that's the kind of thing that you start watching for. So just that type of thought process. Don't get pigeonholed into heading down. Okay.
Would it be better to try and push with pressure or push with your ET tube?
Well, we had already placed our ET tube where it needed to be, and so we just went with the proper placement. And we're like, well, we know this is in the right spot, so let's just go from there. If you knew exactly where it was at, I think it'd be a little bit easier to use your ET tube.
Because if you knew it was blocking both, you might be able to push it to the right veins in the tube.
All right, get your velar sac. You all know about the anatomy related to this, right? With the elasticity, surfactant, for COPD patients. Diaphragm contracts, thoracic volume increases, yeah? So where does the diaphragm go?
Down.
Down. Okay, so diaphragm drops down, so what does that do to your intrathoracic pressure?
Negative.
Okay,
Decreases.
so where does gas how does gas flow then?
From negative
In.
to positive.
I'm positive.
From high to
Positive
low.
to negative.
There you go, from high to low, right? So diaphragm drops down, getting negative pressure in there, so that's gonna suck the air in, right? So then your diaphragm relaxes,
Pressure increases. And
forcing it out, right? So it's designed to work on its own, and you don't have to do a lot of thinking with it, okay? You guys will, once we hit some of the trauma stuff, some of the stuff you guys are gonna start looking for is diaphragmatic rupture in trauma, because what can happen is, if this diaphragm ruptures, right? So you can end up blowing it out, and you can end up having part of your diaphragm up into your lung cavity here, okay? So say this ruptures up, you collapse your lung here. You think you would want to decompress a chest with the ruptured diaphragm?
No.
It's just one of the indications to watch for. Have I ever seen it? No, I've never seen it. It's one of those things that they say, don't decompress the chest if you get diaphragmatic rupture, because you're gonna rupture this, and what's below the diaphragm?
Stomach, intestines.
Intestines, right? So all your intestines and everything start to fill up your chest cavity up here, right? So now you're gonna stick a needle into bowels and intestines and stuff like that.
Will they get that high if we're going second intercostal?
So if you are completely collapsed, right, if you're in a tension pneumothorax, so that means that the whole thing is shifted probably. So you're getting tracheal shift, you're getting, so there has the potential for this entire cavity of filling up with stuff. Right? Like I said, have I ever seen this? No. Have I
How
ever
would you
have,
see that?
huh?
How would you see that in general?
So it's a sunken abdomen, so the abdomen basically becomes concave, so it's really, really depressed, and they become almost barrel chested. So like a COPD patient, really, really sunken abdomen. And so, like I said, it's not something that I've ever seen. They just talk about it in all the literature and stuff about not decompressing. So, all right, pulmonary obstruction. We have asthma, bronchitis, COPD, emphysema. Those are the big ones that we're going to treat, right? Those are the big ones we hear about. Yes? Everybody agree? All right. So asthma, bronchospasm. Yeah. So all that smooth muscle in there. What's it do?
Constricts.
Yeah. Does this? Who has asthma? Who does this happen to?
Kids?
Lots of children, athletes.
Can
Small
anyone have bronchospasm?
Yes.
Yes.
Can anyone have asthma?
Yes.
Yes.
So, with asthma, is asthma usually a diagnosed condition? Yeah, you're said, hey, you got asthma.
Yes.
Do you have to have asthma to have bronchospasm?
No.
No.
So, I don't have asthma, but could I end up with wheezing and broncho,
Yes.
If you develop an allergy to something,
okay? Or what other kinds of things can cause bronchospasms?
You can inhale something.
Well, everybody had an opinion, yes.
That's an exercise.
Exercise,
Smoke.
smoke, so
Altitude.
inhalation issue, altitude.
scuba diving.
Okay, so altitude changes in your thoracic pressures.
Weather.
Anything else?
Pollen.
Allergies?
Would there be something with choking on water or swallowing water?
Irritation?
Irritation.
Irritation causes inflammation. Yeah, so all those things, just because you don't have asthma being diagnosed asthma, doesn't mean that you don't necessarily are completely off the list of bronchospasm, right? So just because if you go on a patient that says, hey, you hear them wheezing, you're like, oh, do you have asthma or some sort of respiratory condition? No. It's like, oh, well, maybe you do now. Maybe you have some other thing. So this is where you have to investigate a little bit and try and figure out what's going on with it. How far down does asthma affect? How far down does it go?
Bronchioles. Bronchioles. Almost to the alveoli.
Does the alveoli have effect down there?
No.
No.
No, so it's not really affecting the alveoli, it's more in the bronchioles, right? Bronchioles and bronchus. If it's all the way up into the bronchus, then it's a pretty significant case, right? All right, so you end up with edema in the inner lining as well. Do you always have edema? No, right? Secretion of mucus. Do you always have mucus?
Yeah.
No.
No.
It could just be the muscular aspect of it where it's spasm, okay? So you have different approaches here. So you got your inflamed, so people that have like your inhalation injuries or something like that, or irritated based on water, or extra mucus production. So either one of those can cause asthma. Asthma presents with what kind of lung sounds?
Wheezing on exhalation.
On
And
what?
on-
Exhalation.
On exhalation. Can they wheeze on inspiration?
Yeah.
Yeah. If it's bad enough, absolutely. But
That's
the
bad.
primary presentation is exhalation, right? So why is it on exhalation they're having a hard time? Why are they wheezing on exhalation?
Because you're pushing a smaller amount of air through your vocal cords.
No, think about
No.
it. It's below your vocal cords, so it's down in your bronchioles. This is where you're going to get your wheezing. It's in your chest wall. So think about the speed at which the air goes in and out. Okay? So when you inhale, everybody take a deep breath, or just breathe deep, take a normal breath. And then take an exhalation.
Faster.
It goes out faster, right? So the speed at which it travels through these narrow vessels, narrow bronchioles, I mean, is what is going to trigger those. So this is where, yes, you can absolutely get it on inhalation, because what usually happens, you're at the late stages of asthma, so what is now happening on inspiration? If you're having a
You're
hard time
hyperventilating.
exhaling, so are you gonna start breathing faster, trying to compensate for it? So you're gonna start breathing fast in, fast out, which is then gonna cause inhalation and exhalation wheezing. Make sense?
So you're behind.
So you are behind. There we go. All right. So common symptoms are cough, wheezing, exhale, dyspnea, phlegm, right? So if you eliminate the wheezing, does that sound like a common cold a lot of the time? Yeah? So one thing that drives me crazy as a paramedic watching new paramedics is walk in and they immediately hear somebody say, hey, I'm having a hard time breathing, I got this cough. What's the new paramedic do? Hey, we need to start this person on neb treatment. It's like, okay, we've not gotten the whole picture yet, right? So do we automatically start treatment without our whole picture?
No.
No, right? So we gotta listen to our lung sounds, right? So lung sounds are very, very important in respiratory emergencies because that's gonna tell you a ton of what is going on with your patient, whether it's pulmonary edema, whether or not it's asthma, whether or not you got stridor, where you got obstructions. It's gonna tell you a lot of what it is that you are actually looking at. So as a paramedic, do you say, hey, if you're teching, you'd be like, hey, Mark, can we give me some lung sounds for me real quick? Why?
Subjective.
Making treatment decisions.
Still haven't answered my question.
You wanna know if it's
Do you
changing
want
when
them
you
to not be
reassess?
talking while you're listening to lessons?
So, kind of what Dustin says here. So you listen initially, right? Are you gonna do some treatment then? Probably. So then, what happens if Mark listens first, and then I listen second after the treatment?
Depends what you're listening for.
Am I gonna know if things are better or worse? Well, if all of a sudden there's no lungs, if all of a sudden there's no wheezing at all, I'll be like, yeah, we fixed it. Or it's like, oh, well, maybe Mark doesn't know what he's listening for yet. Or maybe Mark has a different opinion of what wheezing are to him versus to me, right? So when you guys start your rotations, listen to as much lung sounds as possible. When you guys do your internships, listen to as much lung sounds as possible in the back of the ambulance, because wheezing in the back of an ambulance is a lot different than wheezing in a house, right? Because why?
All the other noise.
Road noise, right? Road noise, engine noise, patient noise, equipment noise. So listen as much as possible. I had a super awkward moment in the ICU when I was doing my clinical stuff. This guy, the nurse was like, hey, come over here. I got an awesome pleurisy, pleuritic rub. I'm like, oh, cool. So I go there and I'm like listening and I'm like, yeah, totally, I hear nothing. Like I'm just like, he's like, yeah, listen right there. Yeah, you hear it? And I'm like,
Yeah.
no. He's like, really? I was like, yeah. I'm like, I didn't even know what I was listening for. I didn't even know like what a pleuritic rub what it sounded like. So I'm just like, sounds like lung sounds to me. And this was like one of my first clinicals. So I'm just like listening around. I'm just like, he's like, okay, well, lift it up here and listen here. I'm just like, okay, yeah. And he goes, okay, now lift it over here and listen here. I was like, oh, still not loud. I was like, I see, but I heard a very slight difference. But if I didn't know that was a pleuritic rub, I would have just automatically assumed that was just other lung sounds, just normal lung sounds of this person. But because of the fact that this person was there and was pointing out, hey, listen here, this is normal, and now listen here, this is not normal. Oh, okay. Me, I would have been like, no, yeah, clear lung sounds, sounds good. Don't know. So I don't know. Do you guys take your own stethoscopes with you guys? Nobody?
I'm gonna start.
I think
Are you supposed to? Is that part of? Yeah, I would definitely recommend having your own stethoscope and just listening, because you don't want to grab somebody else's stethoscope, and the nurses are usually pretty possessive of theirs. But make sure you get good ones that you can actually hear and make sense of. They're comfortable, they don't jab your ears kind of thing, because then you're not going to want to do it. But as much lung sounds as possible, you want to listen to those. Just so you can recognize, okay? So triggers, we talked about that. So allergies, exercise, additional medications, viral infections, right? So somebody that has some sort of increase in mucus production, that's going to cause the ability for your bronchioles to potentially spasm. Wheezing and other signs of allergies. If you hear wheezing expiratory as you walk up to somebody, good or bad?
Okay. Well, you can hear it. It's moving.
You don't even have, well, you can hear it before one sounds.
If
It's
you
not
can
great.
hear it, if you can hear it from me to Dustin and you hear them wheezing, is that good or bad?
Before you put the stethoscope
Before you put the stethoscope on.
Bad.
Bad. Is it okay to call for a neb treatment at that point?
You don't have the full picture.
Nice, thank you. Because can somebody have just like, can somebody, hey, oh man, I could do it, but I'll start coughing, so I'm not gonna do it. So when I run scenarios with you guys, like I can legitimately create inspiratory and expiratory wheezes with my throat. And like my throat gets sore after a while doing it, from doing scenarios with you guys. But people can create a wheeze in their upper airway that has nothing to do with asthma. Okay, so you have to, yes, you are thinking that's what you want to do. Yes, I probably want to give this person a neb treatment, but I want to listen to the lungs just to make sure, right? You want to make sure, because you'll get times they have this upper thing and you're just like, okay, they're wheezing up here, but you listen to the lungs and they're totally clear. And then you're just like, wait a second. Okay, something's up, like, okay, is this more of a psych issue? Are they emotionally upset? What's going on with that?
Could that also just be like an upper respiratory obstruction of some kind?
Obstruction, infection, yeah, absolutely. And so that's why you have to listen to those lung sounds to figure out what you're gonna do before you do it. Okay. All right, so how is an asthma patient going to present? Does anybody in here have kids with asthma? Nobody? Lucky you. Oh, my middle daughter has seasonal asthma based on allergies. So, what do you think the worst feeling ever is in the middle of the night when she walks in? She's like, Dad, I can't breathe. Dad, I can't breathe. It's like, oh, geez. It's like, because she's one of those kids that is just like, she won't, like, she plays softball, does that whole thing, but she won't, like, if she has a hard time breathing, she'll go to like the corner of the dugout and just kind of hide there, like, until it's her time up, because she doesn't want people to see. So when she comes in and she's like, Dad, I can't breathe. And it's just, I'm just like, oh, jeez. All right, so asthma, what's the generalized presentation you guys would expect from somebody that has asthma?
Intercostal muscles are working extra. By the time they call us, the breathing is pretty bad.
What do most asthma patients have?
There's-
Inhaler and anxiety, right? And so most of the time, do they manage themselves? Yeah, right? So they manage themselves, so usually they've tried what?
Albuterol.
Try their inhaler.
They tried all their inhalers, they tried all their neb treatments.
Breathing techniques that they can
So, bad presentation? As in poor presentation? Like, this is not good presentation?
Yeah.
Yeah, usually. Sometimes we go and they're just generalized shortness of breath and they're just like, you know what, I think I got a cold on top of this asthma, blah, blah, blah. Yes, absolutely. But legit asthma patients can present very, very far behind for us, right? So they've already used 2 or 3 of their nebs. They've tried their inhaler. So what are we gonna do?
Solid Medrol?
Good.
Because you just did that.
Yeah.
Oh, did you?
Oh, that was one of our new
No,
meds.
that's one of our new
Oh, one of
meds.
the new
That's
ones.
right.
But it won't take effect right away, so that's
How
not.
long does it take to take effect?
3 to 5 minutes.
Okay,
That's right.
much longer than that.
Yeah, I couldn't get
Yeah.
a good.
You will not see effects from Solumedrol, but will it help the patient? Absolutely, right? So, but Solumedrol is far down our treatment thing, right? So, let's just paint a picture for you. All right, you have a 22-year-old college student was out practicing track at Hayward Field, walks across the station. You happen to be hanging out at Station 13 there, right by Hayward Field. Walks over, says, "Hey, I'm having an asthma attack." 1 and 2 word sentences, inspiratory, expiratory wheezes. I took 3 of my puffers before I got here. So, presentation, go. Questions, what do you want to know?
Lung
What
sounds,
have you
history
done?
of asthma, any allergies? Is this asthma? Is this
before TB?
anaphylaxis?
Geez, okay, so let's see here. History of asthma, yes, because I told you I took 3 inhalers.
Right.
What did you do last time to fix this? Or has this happened before? What
Yes,
did
it's
you do
happened
last time?
before.
And what did you do, what did they do to fix it?
They gave me some sort of breathing thingy.
Okay, did that help? Did that
Seemed
help?
to, yeah.
Okay, so,
Okay. So lips are cyanotic, fingertips are a little bit cyanotic as well.
To me, it's like
So-
lung sounds and treat, because it sounds like it's getting pretty bad.
Or I wanna get like a blood pressure.
So you have inspiratory, expiratory wheezes throughout, all fields.
Okay,
What was the question?
Are they anaphylactic allergic to anything?
Not that I know of.
okay.
Just my Gatorade. Let's see. 1, 2, 3, 4, 5. So table 4, that's being very quiet back there. You guys got any questions? Figure let your partner ask all the questions.
Our partner seems to be doing a good job.
No, classic partners. I'm just a tech, I don't know what's going on. Those are the best ones. And they're like, hey, what's going on? I don't know, I just drove. Oh, you have no clue, huh? Nope, really I don't. I checked out. It wasn't my job. It's like,
I drove.
all of a sudden they said code 3, so I drove code 3.
I worried about getting that.
What's her other vitals, like, stats and rate?
So sats are 87%, rate is 140. What else you want? You want blood pressure?
What was her respiratory rate?
What?
I would.
Yeah, you want it? Or
Yes,
no,
I do.
you do want a blood pressure. Okay, blood pressure is 145 over 88.
Are you still standing up,
So-
walking around?
So that's not anaphylaxis.
Yeah, I'm not worried about anaphylaxis.
Okay,
yeah.
good. All right, so.
So
Oh,
neb
yeah,
treatment.
the neb
I'll
treatment.
be
Give the
alright.
neb treatment.
Give the neb treatment.
Everybody agree with the neb treatment?
Yes.
Yeah,
All
as long as they don't
right.
allergies.
So you started neb treatment. Now what?
We can't talk to her for a while because.
Oh.
So.
Focus on
You can talk when
breathing.
you're doing it now.
So, I've only done this once before, I don't know how to do this.
Coaching.
Okay, how would you do this?
As deep as you can, take nice deep breaths.
Mouth all around.
As low as you can into your lungs.
Hold it.
Don't talk because when you talk, you're not feeling. Try and limit the amount of
Actually, yeah.
medication that goes out in the tubes, so you're trying to
We
focus.
could put on the NRV.
as much as possible.
Okay, good. So, non-breather would be a good approach as well, if she's unable to hold it and follow directions, right? You just put everything there. But yeah, you wanna coach them on like, all right, so I want you to take as deep of a breath, and about every third breath, I want you to take as deep of a breath, and I want you to hold it for an extra second or two. So then you're holding that medicine down, so you're not forcing that exhalation immediately, because somebody with asthma, what are they doing? They're breathing off just as fast as they're breathing in. So you try and get them to hold that medicine in there, so it gives the medicine time to get there, instead of them, all that dead space that's happening, you're basically moving the medication up and down, it's not making it down, right? So you want to try and have them hold that extra second, and you gotta coach them through that, because somebody with shortest of breath, do they wanna hold their breath?
No, the anxiety on top of it isn't helping.
Exactly, right? So anytime somebody's short of breath, anxiety's gonna be through the roof. A lot of times, will these people have increased volume of voice? Are they gonna start yelling at you at times?
Yeah.
Especially
1 to
a-
2
a
sentences.
Older
1 to 2 words.
male population that has a history of this, they're gonna yell at you because they want specific treatments at specific times. And if they're not getting it in a timely manner, then their anxiety's gonna go through the roof, and they're gonna get bad, and then they're gonna start demanding stuff, and they're gonna start yelling at you, right? So what's your job in that case?
Calm down.
So you gotta do everything you can to coach them, let them know you are getting the you're getting the treatment ready, you're getting it ready for them, we're gonna get it for you, we're gonna take care of you, okay? You gotta just reassure them that it's coming, right? Like, they're gonna be like, hey, it's like, is this your first day kind of thing? But no, it's like, medication's coming, we're gonna get you the med, we're gonna get you the neb, we're gonna get you feeling better, all right? You just can't let them control what you're going to do, which is one of those pigeonhole things again. I need this as soon as you walk through the door. Okay, get it for him. It's like, no, hold on. Yeah, all right. You can say, okay, well, let's work through this, right? Get our history, figure out. It's like, oh, do you have? Hey, I need a neb treatment. Oh, do you have a history of asthma or respiratory problems? What do you think he's gonna say? Yeah, right? So 1 and 2 word sentences. They are very good at yes or no questions. Those are very good ones to ask, especially if you are trying to head down that respiratory direction. You're just like, do you have respiratory problems? Yeah. Do you take inhalers? Yeah. How many have you taken? 4. Okay. All right. So did they work? No? Okay. We're going to start to get this ready. As they're starting to get it ready, listen to the long sounds. Hold on just a second. Maybe not. Right? So this is where you start to create that picture and stuff and develop your case for, okay, yeah, we're going to go with that next treatment.
As the next treatment is being prepared, you just put on non-repeater
No, if
for
they're,
what they are breathing, like.
You can hook it up straight to
Before
the,
you're, like, you do lung sounds and you can hear the losing of septum.
depending on how bad they are, you'll start off with a non-rebreather potentially, and then you would just plug the neb straight into the non-rebreather if they're in that bad a shape when you show up. But the fact that this person came across the street, was there, able to talk a little bit, that's somebody that would need probably coach through a neb treatment. Okay. All right, first neb's done.
Is there a detriment to a neb? Is there something other than increasing cardiac symptoms? Is there something bad from doing a neb treatment?
No. Cardiac is the only real negative aspect. Increased cardiac workload, it potentially increases heart rate. So what was her heart rate already?
High.
So it's high, right? So this is where you have to weigh, is this cardiac related increased heart rate? Is this anxiety related? Like what's causing that increased heart rate? So is that something you're gonna be paying close attention to as you're giving the neb? Absolutely. Right?
What is the reasoning behind not letting basics do Atrovent with albuterol?
I would guess probably because the Atrovent has increased cardiac and it lasts longer. It's the long duration medication of the two. And so maybe they're like, well, if you, for some crazy reason, would give Atrovent and it was the wrong medication that can increase cardiac work.
Wouldn't last.
Yeah, that would be my only, I couldn't tell you the exact reasoning why, because it's pretty benign, it's very minimal cardiac effects. So, to be honest with you, I would argue, I would argue that anytime you give albuterol, that you would automatically, it's such a benign medication that just come on to it.
Would you ever withhold a neb, like if their rate was really high and they've hit albuterol more than their prescribed dosage, like they've done it 5 or 6 times and it hasn't been working? Would you ever?
Would I ever withhold a neb? There would be times where I would skip a neb. It'd be a rare case because what would my next drug of choice be? Nope. If I'm thinking about skipping a neb, I'm not quite there yet, but I'm getting close. Epi, right? So anybody under 40, you don't have to call MD for, but basically you're treating it similar to an anaphylactic reaction, like you're trying to get that bronchodilation effect. And so now, think about it, so you're already tacky, and now you're loading up with this, so now you're really starting to weigh that cardiac overload that you're causing. So it's going to start to become judgment calls on, okay, is the heart rate increased because of the albuterol, or is it increased because of anxiety, or is it increased because they just can't breathe? So you have to, it's going to be a judgment call, and you guys are going to be really bad at your judgment initially, because you're not going to have been placed through the gauntlet those 3 or 4 different times to see, okay, why is this happening, right? And so it's just going to come with experience and kind of almost like a gut feeling of being like, this person is presenting this way, they're presenting as if the albuterol's really jacked them up, albuterol's not working, we have to progress to our next treatment. Right? Obviously, you're going to look at the albuterol, you're going to check expiration, you're going to check to see if it's good albuterol, how old, how method that they took it, that kind of thing.
When we were talking about judging whether it's upper or lower, would it hurt to give a neb treatment to somebody who had upper airway constriction?
No, I mean,
Other than maybe wasting time because it wouldn't necessarily be effective.
yeah, I mean, so what kind of things do we have in the upper airway? Obstructions, constrictions, right? So if your bronchioles are constricted, bronchus is constricted, right? So so let's look back up a second. So what do we consider upper versus lower?
Above the trachea? Or above the,
Epiglottis.
epiglottis?
Okay, so you have something up in here, right?
Mhm.
So what is the potential, so what kind of things occur up here?
Epiglottitis.
Okay.
Anaphylaxis. It's nothing, yeah, like croup.
Oh, well, I mean, if we're gonna fast forward, we might as well just fast forward and bounce around, I can bounce around. Good, right? So we have epiglottitis and croup, right? So those are just the infection aspects. So what would happen if you gave somebody with epiglottitis, a nebulizer?
Nothing. That is
It wouldn't affect the inflammation.
Has the potential of making it worse?
why.
So what do we wanna do with epiglottitis?
Don't we
Decrease
give,
inflammation.
So your
Like
epiglottis
salt
is
water?
ginormous, right?
Yeah.
Mm-hmm.
This huge floppy thing that's back there, right? So do we want to do anything that could increase heart rate, anxiety, anything like that? No, right? Does albuterol and adjuvant have the ability to increase jitterness and anxiety and? Yes. So do you think giving somebody with epiglottitis neb treatment would be a good idea? No. So this would be a time when you'd be like, no, probably not, right? What do we do for croup?
It's just inflammation of that, or the back, so, same thing.
Same thing, what?
It would, well, I would say epi, but if you give a neb treatment to someone with croup, it would have the same effect, you would get increased anxiety and stuff, which wouldn't help either.
So what do we do? You guys, somebody said what we do.
We
Give
do-
epi to this patient, right?
and
But we
just
give it
a
differently.
neb treatment with
We
salt
give-
water, saline?
Nope, so we actually give
For ceiling?
epi in the neb treatment, okay? For croup. So what kind of effects do you think that's gonna have back there? What does epi do?
Vasoconstrict.
Vasoconstricts, right? So before we get to croup, what kind of things are we gonna do before that? Because we don't wanna just jump straight into epi and throw an epi on somebody that's having respiratory distress, right?
Snowing sounds.
Because
Okay, lung sounds are clear.
Get a history.
Does everybody know what the classic presentation of croup is? Seal bark cough. I mean, it's legit. When you walk through, you know exactly what it is.
humidified air.
Okay, yeah. So if it's a hot, or if it's a cold day outside, like right now, and you walk into this room right here, and you have the kid with, most of the time they're pediatrics, the kid with a seal bark cough, what are you gonna do with them? First thing you're gonna do is you're gonna calm the parents down. All right, because the parents are gonna be wound up because they called you, right? The second thing is what are you gonna do with the kid?
You're gonna call a doctor and.
Take them outside.
Take the kid outside. Take the kid outside. Most of the time, if you take the kid outside, the kid's gonna start breathing better almost instantaneously. All right? Has anybody in here had anybody in their family ever have croup? Okay? And were they better, did they have to be treated, or were they able to manage themselves by staying out of the hot wood stove environment?
They just took me outside.
Yeah, so that's the thing, it's like most of the time you'll walk into these houses and it's winter time and somebody has a hot wood fireplace going and the kid is just coughing up, just coughing and coughing and coughing and coughing. Now what happens once the cough starts? It just keeps going and going and going and going and going and then they can't get control and then what do they start to do? They start to turn a little cyanotic and then the parents really freak out because the kid won't stop and really all they really have to do is take them outside, right? Take them outside. The other thing you can do is get them in a humidified condition. So like where would a good place to be?
Shower.
Bathroom or the shower.
A shower, right? Get a nice hot shower, steam going, get that steam to help them. Okay? So those are two very easy, quick fixes that doesn't have to get to epi, right?
You get to epi, then that's what's gonna happen. It's gonna be 5 mils, 5 mils of 1 to 1,000 in neb treatment. And, basically, they're gonna breathe on it and you're gonna listen to them.
So 5 mils, is that 5 milligrams as well? Isn't it 1 milligram per milliliter?
Yeah. So you just basically let them, do you give them the whole thing? Probably not. You're gonna monitor them as their breathing improves, you're gonna continue to keep their heart rate under control. And because, did it go into the bloodstream?
Yeah,
Is that a ton of,
yeah.
Yes.
yeah, so make sure that you continue to monitor your patients for that.
Could you do just a saline neb? Would that help as far as humidified air?
You would think so. Yeah, I mean, it used to be that we would carry humidifiers for this exact kind of thing, where you could warm humidified oxygen for both hypothermia as well as related things, and they took it all away. It used to be that they would do alcohol updrafts for this as well. All just different treatments for it, but they really started to eliminate a lot of those quick and easy fixes and simplify things for everybody.
Which is outside, hot shower.
Yep.
How do you do a hot shower with a patient in their house?
You
You
just take the
suggest it?
bathroom, close up the bathroom, turn the shower on as hot as you can. You don't actually put them in the water, but you keep them in the steam
In the steam?
coming through.
Is that something you take the patient in there to do, or you bring suggest the family to do?
We do it as a group. Yeah,